episodes of vomiting and diffuse abdominal pain. Fever was not associated with any kind of erythema, rashes over the body and joint pain, and fever was totally unresponsive to the oral paracetamol tablets. The personal history of patient was she was unmarried with normal regular menstrual cycles. She had no history of outside food intake, no history of waterlogging around her house or workplace, no significant history of medical illness and allergic reactions. There was a significant history of mouse breeding in her wardrobe was given by her brother. So, she was on initial clinical findings where she was average built, well nourished, conscious, cooperative, restless with toxic look on her face, which we can see hair on her face, and she was moderately dehydrated, febrile with the temperature of 103 degree Fahrenheit. Peripheral cyanosis was present, mild pallor present, no icterus edema generalized in lymphadenopathy, but her conjunctiva was red and ecchymotic, which we can see in this picture also. On clinical examination, the chest showed bilateral air entry present, vesicular breath sounds, although bilateral basal crepitations were present. CVS was normal, S1, S2, no added sound, and abdomen diffuse tenderness present all over the abdomen. Pulse rate was more than 150, BP 90/50, pulse rate as respiration rate 24 per minute. SpO2 level was falling. It was 89% on room air. So when examined, the extremities were examined, the hands and feet were cyanosed and cold. The peripheral cyanosis progressed very rapidly to involve the proximal parts. Although the peripheral pulses were present, but the signs of digital gangrene was quite obvious. So it was quite obvious. The course of illness and treatment in the hospital. This patient was admitted directly. It was so, the patient's GC was so poor that she was admitted directly to the intensive care unit and advised for temperature charting at 4-hourly interval, regular monitoring of vitals, proper positions, moist O2 supplementation to maintain saturation level more than 94%, fully catheterization, input-output charting, fast IV fluid, RLNS bolus to correct the dehydration, and she was put on the broad spectrum antibiotics injection, meropenem 1 gram IVTDS, doxycycline, and also the liposomal amphotericin B was started at the rate of the 3 milligram per kilogram per day empirically. Injection paracetamol, injection pantoprazole were also started. Samples were sent for the lab investigations. Patient was advised for the CECT chest and abdomen. In spite of best initial efforts, patient developed signs of sepsis. She was put on the inotropic support of noradrenaline infusion to maintain blood pressure and also intubated and put on ventilator support. Rice tube fitting was also started. So after 1 day, next within 2 to 4 hours, the lab reports started coming, and it showed the CBC hemoglobin percent was 9.2 gram per TL. TLC count was very much high, 20.6 into 10 to the power 3, and the platelet counts were very low, only 20,000. Urea RFT was also deranged, showing serum creatinine level of the 3.3. So serum sodium and potassium levels were almost normal. The LFT was also slightly deranged. PT INR was quite high. It was 2 INR was 2.07. Procal was very much high, 63.1. complement C3, and C4 was in the ratio of 32.2 is to 11. Fibrin, or moreover, the fibrin degradation products were more than 20. LDH were more than were 1154. CPK, CKMB, and tropi, these were also slightly elevated. These were also elevated. Then other or more and more tests started coming out on the next day. ANA test, PCNA, Leah vasculitis panel was negative, chikungunya, malaria, peripheral blood smear for malaria parasite, typhoid test, dengue serum, all were negative. Only one investigation, that was the leptospira antibody, showed some positive results, that IgG and IgM, both of them were elevated. Patient was tested for the UPT test, that was negative. Routine urine showed high number of RBCs, and WBC also were present in the 3 to 5 WBCs. Paired blood culture, urine culture, endotracheal tube secretions culture sensitivity, AFB stain, fungal stain, gram, all fever workup were negative. High baseline swab showed Klebsiella pneumonia. But the CECT chest report showed extensive right lower lobe consolidation and diffuse patchy spaces along with the ground glassing suggestive of the ARDs. So the whole event progressed so rapidly, and it showed the ARDS within 24 signs of ARDS within 24 hours. Course of action in view of all these reports. Blood transfusion started. Patient was advised for PRBC 2 units, followed by injection of torsemide. Then platelet infusion 6 unit RDBT PC oblique 1 unit of SGPC. SLED was also done in view of the AKI. In spite of the best critical care approach, patient continued to deteriorate. Features of multi-organ failure where prominent. Poor prognosis was explained. So this was the pictures of that girl when she was admitted in the ICU, and she was not at all improving, and lastly she started showing signs of sepsis and mortality reported after 5 days. So this was the case, and it was one of my lifetime experience. So the diagnosis of this case was made that the leptospirosis, and one of that, the vaginal swab showed the infection of the Klebsiella infection also. So we'll focus on leptospirosis only. So leptospirosis is an acute and sometimes severe spirochetal infection. This is most widespread zoonosis, having worldwide distribution. Global burden is estimated to be more than 5 lakhs per million cases, for more than 5 lakhs cases per year. High prevalence of 975 cases per lakh population in some areas. Several outbreaks in Guyana, India, Philippines, and Thailand in last decade were reported. High prevalence in humid tropical countries is found, and heavy rainfall and consequent flooding is usually precede the outbreak of this disease. So this is the publication on the global burden of the leptospirosis, estimated in the terms of the Daly laws, showed that the leptospirosis is a neglected emerging zoonotic disease, especially within the economically vulnerable populations such as the urban slums dwellers and the rural subsistence farmers. This is the global background, that where it is most common in the African countries and Guyana, and it is also common in our India, where we are having hot humid climate in this years, in the month of June, July, August, and September. So let's have a look on the causative agent. This is the spiro-causative agent is a spirochete called Leptospira. These are thread-like slender. These are thread-like slender motile with hooked ends when visualized under the dark-filled illumination with silver staining. At present, 23 subgroups and 200 serovars have been recognized from the various parts of the world, and only the strain Leptospira enterogans are pathogenic. Source and reservoir of infection. Source of infection is urine of the infected animals. Leptospira are excreted for long time, probably entire life, especially in cases of the rodents. Reservoir of infection, the infected wild and domestic animals, especially rodents such as rats, mice, and voles. Most of these domestic animals are infected through grazing in areas contaminated by the carrier host. This is the rat is the reservoir and how they are infected. So these are the infected animals. These are the grazing in the field of field livestock and domestic animals, and how they are transmitted to humans as zoonosis in the hot and humid climate. So what are the risk factor? There is a host risk factor and environmental risk factor. Host risk are the children and young adults of lowered immunity, farmers working in rice and sugarcane fields, laborers working in the underground sewers, meat and animal handlers, and veterinarians. The environmental risk factor is poor housing, limited water supply, inadequate method of waste disposal. The environmental contamination with urine and feces of reservoir animals due to all above combined to make disease significant risk for poor population in both the rural and urban slums. So what are the ways of transmission? There are three ways of transmission. Either it could be due to direct contact with the urine and feces of infected animals through skin abrasions, or even intact mucous membrane. And this is very much common in rural areas when the people walk barefoot in their fields for going washroom or for defecation. So this is very common among these farmers. The indirect contact is the ingestion of contaminated foods, water, and raw vegetables. And droplet infection is the environmental contamination with the urine and droplets of the infected animals, which is very common in the urban slums. So what are the clinical features and course of action, a course of illness of the leptospirosis? It may present with milder sign and symptoms, which is called anicteric leptospirosis, or may present with the severe clinical picture of the icteric leptospirosis, which whose case I have presented in this presentation. So the incubation period is 10 days, ranges between 4 to 20 days, and average is 10 days. Anicteric leptospirosis, this is very common and more common, and is having mild clinical presentation, biphasic with two distinct septicemic and immune phase. The septicemic phase begins with abrupt onset of the high-grade fever with chills, abdominal pain, severe headache and myalgia, especially of the calf muscles, marked subconjunctival hemorrhage. Leptospira can be isolated from blood and CSF and tissues. The initial septicemic phase is followed by a 3 days of improvement in symptoms and signs, and also absence of fever. Immune phase, there is recurrence of symptoms and onset of meningitis, unilateral or bilateral uveitis, involvement of entire uveal tract may be seen, rarely hemorrhagic pneumonia may be seen, and leptospira are now absent from the blood and CSF, but are still present in the kidney, and specific antibodies appear. So now the prognosis: illness is usually self-limiting, lasting for 4 to 30 days, and complete recovery is a rule. So in mild cases, we can expect the recovery of the patients. Now, coming to the ecteric leptospirosis, this is also known as the Wales syndrome, most severe form of disease. This is characterized by impaired kidney and liver functions. All the above signs which I have discussed earlier. Besides, it present characterized by the impaired kidney and liver function, abnormal mental status, hemorrhagic pneumonia, hypotension, continuity of sign and symptoms as above. Prognosis is poor and the mortality rate is 5 to 40%. So diagnosis, history of exposure to the, how diagnosis is made by the history of exposure to the reservoir animal, clinical features and supportive lab findings. WBC count may be normal or as high as 50,000 per ml. Patients start showing the features of deranged KFT, that is the oliguria, proteinuria, hematuria are common, and in severe cases, uremia may occur. Okay. So may be present, and LFT is the elevated bilirubin, and aminotransferases are seen in the 75% of cases. Serum creatinine kinase is usually elevated. Now, what the microscopy shows: in early disease, organism may be identified by the dark field examination in the patient's blood. In case of meningeal involvement, organism may be found in the CSF during first 10 days of illness. Cultures become positive in 1 to 6 weeks, may remain negative if antibiotics started before sample collection for the culture. Serological test, microscopic agglutination test, ELISA and PCR methods appear to be sensitive and specific, positive early in the disease, able to detect leptospiral and DNA in blood, urine, CSF, and aqueous humor of the patients. Antimicrobials treatment of choice. Antimicrobials with anti-leptospiral activity are the treatment of choice. That is the penicillin, 1.5 million units every 6-hourly interval, ceftriaxone, 1 gram IVPD, tetracycline, doxycycline in the dose of 100 milligram every 12-hourly interval, orally or intravenously, is the treatment of choice. What are the complications? The complications: myocarditis, aseptic meningitis, acute kidney injury, pulmonary infiltrates, and hemorrhage. All these complications are not common, but are the usual cause of death among these patients. And we have seen all these complications in this 20-year-old girl. So how we can prevent? Prevention is better than cure. So prevention is avoid potentially contaminated food and water. Avoid direct contact with the urine and feces of pets and domestic animals. To check breeding of rodents inside house and stores. Doxycycline prophylaxis is effective in preventing these infections, and human vaccines used in some limited settings, but it's still under trial. So thanks to all of you for patient listening. And any question?
Thank you, ma'am. It was a good presentation. Thanks for your excellent talk. We will take up queries at the end of second session.
Okay, thank you.
Thank you, ma'am. We will move to second session now. The topic is optimization of ADA OHS in a case of diabetes by Dr. Sujit K.R. Mishra, sir. Sir, please start the presentation. Hand over to you, sir. Thank you.
I'm not able to share my screen.
Ma'am, can you stop your sharing, ma'am? Mishra, ma'am.
Okay. यार मैं कुछ stop sharing.
Yeah.
Stop sharing.
Is it visible?
Yes, sir.
Yes.
It is visible.
Yeah. Very good evening to all. I'm loud enough to. My voice is clear.
Yes,
Yes,
sir.
sir.
It is clear, sir.
Yeah.
Please go.
Thank you. Very good evening to all and our chairpersons, Professor Srinivas sir. Today I'm going to present a very common topic, particularly in our rural areas. We are seeing that magnitude of diabetes is increasing day by day. So in this case presentation, I will talk how we family physicians in our busy OPD can optimize the anti-diabetic agents, which are lots of diabetic agents nowadays, and we have a lot of choice, and how we can select and optimize the anti-diabetic patients in our busy OPD in a type 2 diabetes mellitus case. So this is the case, and a 55-year-old male and was suffering from diabetes since 6 years, and is on triple combinations: glimepiride 2 mg, 2 milligram, metformin 500 milligram, and 5 liters 15 milligram. He was taking it before breakfast, and dapagliflozin 10 milligram and voglivose 0.2 milligram before lunch, and tenecliptins 20 milligrams and voglivose 0.2 before dinners. And he said his blood sugar is not controlled since last 2 years. And at every visit, my doctor is adding one drugs. And this is the common scenario we see in our clinics, that most of the doctors, when one drug fails, they add another drugs, and without any optimization. So I will talk about this care, how to optimize. This is the uh, details of this patient. I will talk about this later. And now the question, by seeing this history, the question is, all drugs have been given to the patients, and what is the next step? Is any optimization of medicine is still possible, or we should switch over to the insulins? Insulin phobia is very common, particularly in the rural area, although acceptance are increasing in urban area, but it's still a lot of problem with the insulin in our rural areas. Not only the injection fears, but also have difficulty in the patient is not taking himself the injections. So still a lot of issues. So what do you think, that still optimization of medicine is possible, or we should switch over to the insulins?
Hello.
So before discussing in this patient, I would like to discuss how to approach these patients, but very in simple way, and in our busy OPD, how we should approach, and how should we apply the guidelines to treat any diabetic type 2 diabetic patient in our OPDs. So as you know that guidelines are keep changing. Not only the guidelines are keep changing, even the terminology is also keep changing. Now, recent ADA guidelines says to new terminology about the obesities, about the diabetic, and they recommend to use a respectable language to the diabetic patients. Now they are, if you see the guidelines of ADAs, it was up to 2014, it was a drug centric. Drug-centric means if one drug fails, if any patient diabetic present with a hyperglycemia, they advise to take the metformin. If metformin fails, then there are another drugs and glimiprides, then pioglitazone. Then it was like a art. If you one drug fails, you add another. That was in that case. But after 2014 guidelines was saying it became the glucocentric. Uh, Drug was chosen according to the hypoglycemia actions. So about the side effect of the drugs. So by the art, it was up to 2014. It was a art, but after the 2014, it became the science by seeing the side effects. But after 2020 onwards, the guideline changes to the patient-centrics. So patients come first. Every individual should, every individual should be given individualized treatment, personalized treatment. So now it became the math, not only the arts. Patient diabetic management not became the art or science, but now it become math. And how it's mathematics does work in the management of diabetes, I will talk later. So our DESI guidelines, I find that's a very nice, very feasible approach to we can apply it in our OPD practice. That is the RSSDI ABCDGH approach. If any patients comes to our clinic, our centers, we can approach through this ABCDEFGH approach. I will later I will explain what signifies in the management of diabetes. A stands for the age. Age has a significance in managing diabetes. Then the B stand for body weight or the BMI. C stand for comorbidities and the complications patient presented with in our OPD. Then the duration of the diabetes, that's also important. And we have to see what is the patient has established CVD, cardiovascular disease or not. That also very important in choosing the medications. And the finance issue is very important for us, particularly the family physicians working in the rural areas. Finance is a matters, because if we choose any medication which is out of pocket of the patient, it is not going to help our patients or help us also. And then the glycemic status of the patient. Patient presented with the glycemic status is also important in choosing the medication. I will discuss this later. And the last one is the hypoglycemia concerns. That's also important. So the RSSDI approach, ABCDGH approach is a very, very simple and we can utilize in our practice, and you will see how. Age stand for the age. Patient presented in our clinic at the elderly age are more prone to the hypoglycemia. So we must choose the medications which has least hypoglycemic effects. And if patient is presented young, we can choose a medication which causes little bit hypoglycemia. It helps in the deciding the glycemic target of the patients. So we must not be fixed, very rigid on the glycemic target for the elderly patient, because there is a more chance of hypoglycemia is there. And B stand for the body weights. As we know that more the body weight means more insulin resistance, and the lean body weights means insulin deficiency. So patient presented in our clinic, we must see the sign of the insulin resistance, like acanthosis nigricans. This is the dark velvety patch over the skin folds or the body parts, different body parts. If it is a present, we must aware that the patient has some insulin resistance. Higher BMI means more insulin resistance. Then we must measure the waist hip ratio or the waist height ratio. And in simplify, I use in my clinic just asking patient, what is your pant size? So we can know whether the patient has a higher BMI or has a normal BMI. So by knowing the pant size, the hip. So there are some medication, anti-diabetic agent, which have effect on the weight. There are sulfonylurea and insulin it promote the weight gain. So if patient has a higher BMI and we are choosing medication like sulfonylurea, then it is not going to help our patients. So we must choose a medication which help promote the weight loss, and we promote the metformin, SGLT2 inhibitors and GLP-1 analogs are helpful in promoting weight loss to the patients. And the DPP4 inhibitor is a weight neutral patients. So C stand for comorbidities. Patient presented in OPD having obesity, dyslipidemia, or the CVD complication already present, then we choose medication accordingly. As we know that in coronary heart disease, most of the comorbidities, we recommend the SGLT2 inhibitors and the GLP-1 analogs. As we know that GLP-1 analogs is out of pockets, it is useless to discuss here. If patient presented with any comorbidities in our OPD, we must choose medication. We must include the medication like SGLT2 inhibitors. And there's a pioglitazone should be contraindicated patient presented with congestive heart failure because it causes water retention. So it will increase the load on our hearts. And nowadays, SGLT2 inhibitors is better called as heart failure medication than anti-diabetic medications. If patient is presented with the retinopathy, we pioglitazone is a contraindicated because it causes the macular edema. And if patient is presented with low GFR, we must choose the SGLT2 inhibitors in our the medication, and we by seeing the eGFR, we give metformin accordingly. So duration of the diabetes is also important because early type 2 diabetes beta cell are more active, and as disease are progresses, usually after 8 to 10 years, the beta cell exhaustion occurs. So there is a deficiency of the insulin. If patient's duration of diabetes more than 10 years, 15 years, so and we are giving the secretagogues, so it is not going to much help. So we must choose the medication, anti-diabetic agents, which are not secretagogues, like the sulfonylureas. And if patient has a established CVD, already has a established CVD, we must include SGLT2 inhibitors in our medications. And F stand for the finance. And as I saw that if we are choosing as GLP-1 analogs, and it is a out of pocket of most all of our patients. So although it's a good drug in reducing weight gain, reducing insulin resistance, but it is no use of our patients. And then G stand for the glycemic status. Patient, what is the glycemic status of the patient at the time of presentation? We know that we assess the glycemic status by two ways: short-term glycemic status, and that is why the fasting blood glucose, postprandial blood glucose, and random blood glucose, and then long-term glycemic control by the HB1ACs. And we can assess the severity of hyperglycemia by the HB1ACs. If it is a below the 7.5%, mild. If it is a between up 7.5 to 9%, it's a moderate. And it is a more than 9%, it is a severe. Then we must keep in mind about the glucotoxicity, a physiological phenomenon while managing the diabetic with the anti-diabetic agents. What is glucotoxicity? When there is a severe hyperglycemia, it causes inhibition on the beta cells to functions. When we started medication and glucose get controls, then beta cell start functioning at full-fledged. So there is a more chance of hypoglycemia. So we must keep in mind this phenomenon while managing the diabetic patient with ADA. And then the glycemic target and deficit betweens. We must know what is the current HB1AC of the patient and what is our targets. So that will help in deciding choosing the anti-diabetic agents in our patients. So different HB1AC, different anti-diabetic drugs has a different capacity to lower the HB1AC. This is not exact. This is just a rough ideas to utilize in our practice. Generally, DPP4 inhibitor and SGLT2 inhibitors have a HbA1c lowering capacity is less than 1%. And for the metformin, sulfonylurea, pioglitazones has a in the range of HbA1 lowering capacity in the range of 1 to 1.5%, and the basal insulin has a more than 1.5%, and the basal bolus insulin regimen has a unlimited capacity of HbA1c lowering capacities. So at last, we must have a concern about the hypoglycemia of person. Elderly patients, CKD patient, chronic liver disease patients are more prone to hypoglycemia. So we must choose medications, or we must choose glycemic target accordingly by seeing the comorbidities or the age of the patients, because there is in some groups there is a more chance of hypoglycemias. So this is the very important slides, and again this is just a rough, not just for the clinical practice hour. Bioequivalence of oral anti-diabetic agents. How the individual drugs are efficacious in lowering the blood sugar. That's within group, it's very easy. Efficacies are more or less equal at a recommended dose. Only difference is the side effect. Among sulfonylurea, glibenclamide 5 milligram is equivalent to gliclazide 80 milligram, or gliclazide sustained release 30 milligram, or glimepiride 1 milligram. This is the more or less having equal capacity to decrease the blood sugar level. In the DPP4 inhibitors, all at the recommended dose, teneligliptin at 20 milligram, vildagliptin at 100 milligram, sitagliptin 100 milligram, and linagliptin 5 milligram. They all are equal in decreasing the blood sugar level. Only difference is the side effects. And among SGLT2 inhibitors, they are all the recommended dose, they are all equally inefficacious. But the question arises among the group, how to substitute these drugs that will help in the mathematics while managing the anti-diabetic agents. So among the group, again, it is a rough for the clinical practice. Metformin 100 milligram is equal to glimepiride 1 milligram, is equal to teneligliptin 20 milligram, and remogliflozin or the dapagliflozin 10 milligram, all are equal in decreasing the blood sugar level. And as we know that pioglitazone does not affect immediately. Its action takes times, and when we remove or add, its action takes time. So I have not included in this bioequivalence of the oral diabetic agents. So this is the class of agents. This is just for the revisions. Insulin sensitizers are the metformin and pioglitazones. Insulin secretagogues are the sulfonylureas. Incretin molecules are DPP4 inhibitor or the GLP-1 analogs. And the glycosuric drugs are the SGLT2 inhibitors. These are the, just to know where the site of action, we already know. I'm not going to take time for this. So now coming to our patients, very important, how we should utilize, how I utilize this ABCDGF approach in managing these patients. As Mr. Prakash, whose age was 55-year-old male, and having the duration of diabetes was 6 years, and height was 165 centimeter, weight was 55 kilogram, waist was 80 centimeters, blood pressure is 130 by 80 mmHg. Fasting sugar was the 200 milligram at the time of presentation, and postprandial was the 400 milligram per deciliter, and HbA1c level was the 9%. And his serum creatinine was normal, eGFR was almost normal, and the comorbidities, no any comorbidities. Systemic examination was within normal limits, and he was taking all the medication as I have discussed. So how now I will analyze through my ABCDGF approach. Age is 55 years, so he is not elderly. So there is a less risk of hypoglycemias. So our glycemic target should be tight. We can tightly control the blood sugar levels. Rigid control the blood sugar level. Another B is for body weight and BMI or the waist hip ratio. As we see that his weight is the 55 kg and height is 165 centimeter. In rough, we just do the minus 100 in the height. We get the average weight for that patient. So he is underweight or normal weight. So he's not overweight. So he has no any comorbidities. So no comorbidities. Duration of diabetes is just 6 years. It means still they have some beta, still he has some beta cell function. So there is no established cardiovascular disease. Finance issue was not disclosed here. Glycemic status is the fasting is 200 milligram and postprandial is a 400 milligram per deciliter. HbA1c is 9%. It means he has a moderate to severe hyperglycemia. So there is if I omitted in this patient Voglibos because although its postprandial blood sugar is elevated, but we know that we should fix the fasting first. So if we fix the fasting, then automatically postprandial will be decreased. So as patient is a weight is normal, so dapagliflozin was decreasing his weight, can decrease his weight. So I omit the SGLT2 inhibitors. Then as we know that tenecliptins, incretins and the SGLT2 inhibitors can be given at a maximum dose, can be started with the maximum dose at once. But for the sulfonylureas and insulin, which cause hypoglycemia concern, we have to titrate up and titrate down the doses. Or it also includes the metformin because due to having side effects. So if maximum tolerated dose can be achieved in titrated person. So tenecliptin was on the 20 milligram. It was at the maximum dose. There was no question of increasing this dose. And it is also a weight neutral. So it is best for of this medication. And patient was taking pioglitazone at a low dose, 15 milligrams. As we know that it is a more insulin sensitizer than a metformin. And I increased the metformin 500 milligram to the 1000 milligrams. And the glimepiride was dose increased. And still he has a beta cell functions. So what happened next? So if I increase the glimepiride, I just keep the glimepiride 2 milligram, metformin sustained release 1000 milligram, pioglitazone remains at the 15 milligram and tenecliptin 20. His fasting blood sugars after 15 days come to 164 and PP come to the 284. So if we fix the fasting, the PP already comes down. Then I increase the glimepiride to the 0.5 milligrams and all other remain the same. After 15 days, his fasting blood sugar was a 144 and PP was still 264, more or less same. Then after 50, when I increase the glimepiride to 3 milligrams and all remain same, his fasting become 135 and PP came to the 252. Then I increased later the dose, and when I gave the dose glimepiride 4 milligrams and metformin sustained release 1000 milligram, pioglitazone 15 milligram and tenecliptin 20 milligram, his fasting blood sugar came to 94 and PP blood sugar came to 164. But when I continued it for more than 15 days, his fasting blood sugar came to 74 and postprandial blood glucose came to 110 milligram. Why this happens? This is the very important phenomenon we must keep in this minds. So if patient was going for the hypoglycemia, more chance of hypoglycemia. So I again does the dose glimepiride 3 milligram, metformin sustained release 1000 milligram, pioglitazone 15 milligram, and teneligliptin 20 milligram. His fasting become the 94 milligrams, and PPG become the 180 grams. And then I do the follow-up for the patients. So my take-home message for my case presentation is, for ABCDGF approach is a very useful in the management of type 2 diabetes in our OPDs. And the management of type 2 diabetes should be tailored individually, not in a fixed protocols. Hypoglycemia causing drugs should be titrated slowly, but drug like DPP-4 inhibitor, SGLT2 inhibitors, GLP-1 analogs should be started at full dose initially, as there is a least chance of hypoglycemia. Bioequivalence dose of anti-diabetic agents should be kept in mind while substituting one drug to another, and a glucotoxicity should be kept in mind while reaching target glycemic target. Thank you.
Thank you, sir. It was wonderful presentation. Definitely, it is going to be benefit for rural practitioners. Thank you for your excellent talk, sir. Now I am handovering the session to respected chairperson and speakers for taking up the queries and share their experiences.
Thank you, Ram Prasad. First of all, I thank Dr. Sunil for taking this initiative in organizing the webinars. And we all know how important is rural field, and because majority of the people reside in the villages. Almost 60% of the Indian population reside in the villages, and their conditions are deteriorating day by day, and agriculture was not feasible, and even that is being witnessed by the growing deaths by suicides. Farmer suicides are all over, occurring all over India, and we have recently we have seen the farmers' strikes in North India, Punjab, and so that all shows the living and working conditions of the farmers, these peasants. And I feel this AFPI rural is a very important committee, and it has to work hard to cater to the needs of our population, our majority of the population. And the issues, the health issues are also specific. Suppose if you take Telangana, fluorosis is rampant in some districts. In some conditions, some villages, the diarrheal diseases, cholera is, it occurs commonly. When we were working in the fever hospital, we have seen several cholera cases coming from the villages, not from the urban areas. So specific diseases are prevalent in the villages. We should have a note of it. And I feel it is a very good initiative on the part of AFPI Rural. And I think I'm sure that you conduct similar webinars, concentrating more on the issues pertaining to the villages, pertaining to the farmers or peasants. That I wish that it will, this program will become a successful program. And coming to the two cases, these are the two cases. Dr. Mukul Mishra and Sujit have very well worked up cases. And coming to the first case, it is an acute undifferentiated fever. It's actually very difficult to handle the case because the duration of the fever is only 1 day. Generally, by the nature course of the history, if it is a mild fever, it's a mild leptospiral diseases, it at least takes 1 week or 10 days. But this is a rapid deterioration, and it is a wonderful workup she has done. And whenever the family physicians, the aspiring family physicians should know how to work up the case of fever. First, we have to see whether the sepsis is present or not. If there is no features suggesting sepsis, let us see any localizing features are there, like burning micturition or cough with expectoration, like organ-specific localizing features are present or not. If these features are not present, we have to take it as an acute undifferentiated case. This is what is the case presented by can be considered as acute and undifferentiated fever. In this, we have to see whether it is a continuous fever, intermittent, remittent, and we have to consider so many things: bacterial, viral, and parasitic infections like dengue, chikungunya, and COVID, typhoid, malaria. These are all several diseases, and basing upon the pattern of the temperature patterns, sometimes due to already the patient starts taking the medications irregularly, and they do not confine to the doses. So the exact pattern may not guide us, but we should have an idea of the pattern of the disease. And in this case, almost it has been worked up very well, and almost all the important investigations were done. And dengue, malaria, all the relevant investigations, and the cultures also. In our experience, if a fever cases comes, generally a fever of 4 or 5 days, if it is high-grade fever, generally we ask the blood and urine cultures. Malaria is chest X-ray. The cultures is important, chest X-ray is important. So that is how we work up the case, and it is a well worked up case. And at the same time, we should have in mind one slide of differential diagnosis is also very important. We should keep in mind while working up a case what are the differential diagnoses. A slide can be added.
Yeah.
Differential diagnosis. That is very well, madam. Wonderful presentation.
Thank you, sir. Thank you.
And regarding the second case, and this approach is ABCDFGH approach. I think we generally we may not follow so systematically, but in our daily practice, we follow the ADA guidelines, and we are taught in the webinars, and the endocrinologists, they all follow the ADA guidelines. But almost it is almost similar, I think so. But at the same time, I would like to stress that if there are good studies pertaining to our Indian conditions, if there are some adequate studies, adequate and broad-based multicentric studies, basing upon that, if we have any guidelines like HbA1c levels or the various other factors taking into account, which Dr. Sujit has elaborated very well, and that will be no doubt it is always ideal. Not only in diabetes, in hyperlipidemia, dyslipidemia, in all such issues, still we do not have we follow generally the Western guidelines. But slowly what is happening is, even American Heart Association also, when they are drafting the guidelines, when they are formulating the guidelines, they are taking care of the population of the world at a large, not simply the Western countries' population, but the Eastern countries, Latin America, Africa, Asian, they are taking the samples, they are taking the experiences and the research, everything covering different parts of the world. And they are slowly coming up the guidelines which suits all the areas. And so I think that just like suppose there is a dyslipidemia, by the experiences of the physicians, we can have draft a consensus guideline, consensus statement. That is also our evidence-based, our experience-based. That will also help us a lot. What I would like to stress is we should definitely give priority to the Indian guidelines, the guidelines which pertain to the Indian specific circumstances and in our situations. And Dr. Sujit has managed the case very well, and the various factors which have been taken into account. Similarly, the different approaches, suppose which is the first line drug. Previously, one slide is there, drug centric and glycemic centric. Now it is a patient centric. That is very, very important. And we know that family physicians, they give priority to the patient centric approach. Simply writing a drug, whether it is affordable or not, without and whether it is feasible by a particular patient or not, it is useless effort. We should take into account. We should take the patient into confidence. We should discuss every aspect with the patient, and we have to involve the patient in the decision making. Then only the outcome will be good. That is what I think Sujit has stressed. The present day approach is patient-centric approach, which we all the family physicians should highlight this aspect. Thank you very much, Dr. Ramprasad. Could you please take up one question after another and let the speakers answers the questions.
Yes,
Either
sir. Thank you, sir.
or Dr. Sunil. Please, one of you can in the chat box and please deal those questions.
Okay, sir. Thank you, sir.
I think as such, there were no questions in the chat box as such now. If any of you would want to ask directly, you can ask the speakers directly.
I would like to, very nicely said by Dr. Srinivas sir, that we must, what I would like to say that we as a family physician must be aware of the recent guidelines, and particularly pertain to the India's. And so how we can utilize in a simple way in our clinic. That's also a point. ADA guidelines, although very exhaustive, and what I find that our RSS-TI guidelines is a very simple and we can easily utilize. If patient presented with the patient's age is there, if we started to note the duration of the diabetes, so we can start the thinking about the drugs we choose about. So we can give the personalized treatment to the patients. So we family physician must aware about the recent guideline. So this type of webinar or the conferences, physical conference, will certainly help us to update ourselves. So I will request all to must attend all the webinars or the conference that happens at the regular interval. We must attend and we must update ourselves about the recent what is going in the fields.
Thank you, sir. There is a query. Shall I read the query, sir?
Yes. You read it, Ramprasad.
Yes. Why do patients have different presentations, that is anicteric and icteric? Are there any factors that decide these presentations? Example, immunity, comorbidities, duration of illness, and also would stress dose steroids be beneficial?
I think ma'am is not there. If icteric presentation, when patient presented in severe vascular reaction or severe complication is there, then there is a icterus. And in early, there is a non-icteric phase is there. So we can manage in OPD by giving the doxycycline, I think. Srinivas, sir, what's yours?
Yes, sir. There is no role of steroids in such cases, and
So, okay, we'll move on to the next question. There is, if anyone comes with a fever in a rainy season and we could not find the reasons behind his or fever, so can we think of leptospirosis?
In endemic areas like Bihar, we usually keep in mind that acute undifferentiated fevers in the rainy seasons maybe, or patients, if a farmer or working in a fields, then we can think in acute undifferentiated fever, a differential diagnosis, important differential diagnosis.
And one more question. In some areas, diabetes camps are conducted and monthly free medicines are given. Is it to be encouraged versus the individualized treatment?
Usually diabetic camp are for the screening, not for the managing a diabetic. I think individual clinic is the best place to manage the patients. Just for the screening, just for awareness. That should not be encouraged.
Okay, before closing, Pratyush sir, do you want to add anything before the closing session? Sir, you are on mute.
So first, I'd like to thank Mukul ma'am and sir for a very nice presentation. The presentation have all the ingredients to make it work hour. So we all listen non-stop for 1 hour, and it's a very successful webinar for the sake, because in these times we are having lots of webinars, and to listen a webinar for long period of time at a stretch, it means the webinar was very engaging and it was very informative. Both the presentation was very nice and it highlighted the real world issues. And Sujit's presentation also had lots of talks. So it was very much helpful. What I'll suggest now that we can have a YouTube channel of AFPI Rural where you can upload all the recordings of these webinars.